So I just want to welcome you. For those of you who I haven't met either in person or virtually in the past, my name is Kelly Metcalf, and I'm one of the scientists at Women's College Hospital in the Familial Breast and Ovarian Cancer Program. And Dr. Joanne Katsopoulos and I have been hosting these virtual seminars for over a year now, and they've been very successful. But we knew that there were some unanswered questions that many of you have had, and we haven't been able to get to some of those questions during our scheduled sessions. So today we invited you to submit your questions ahead of time. We've had a close look at those questions, and we have been able to amalgamate them and assign them to some of our experts here today. So like you are probably aware, we have 4 of our expert clinicians here with us today. Dr. Narod was actually unable to join us at the last minute, so we did ask him to record his answers for some of the questions that were appropriate for Dr. Narod to answer. So we do have those for you here today as well. But I'd like to start by introducing our guests. The first guest we have is Aletta, who is a genetic counselor at Women's College Hospital, and she's been with us for a really long time. So many of you may have met with her in the past. Again, she continues to see many of our patients at Women's College, including all of the women who are newly diagnosed with breast cancer, to get them that rapid genetic testing. So thanks for joining us, Aletta. And I also want to welcome Dr. Andrea Eisen, and we're fortunate to have her back here again today. She has given us presentations in the past. And for those of you who have missed some of these presentations and would like to hear more in depth about some of these topics, please go back to our website and you can access those. We have all of the recordings up for you to have a look at. So Dr. Eisen is a medical oncologist at Sunnybrook, and she also is the head of the cancer genetics program at Sunnybrook. So again, some of you may have seen her in the past in terms of genetic testing and management of that risk. We also have Dr. Marcus Bernardini joining us today, and I think he's just having some technical issues getting on with us. So he will join us, and he is a gynecologic oncologist at Princess Margaret Hospital, and some of you may have seen him in your past as well. So he helps with a lot of the patients when they're thinking about risk reduction surgery or treatment of their ovarian cancer. So Dr. Bernardini will be joining us as well. So we do have like I said, the pre-submitted questions. We will put them up. If you do have additional questions that we're not covering today, I would welcome you to post those in the Q&A section. And if we have time at the end, we will be able to get back to some of those questions for you at the end and pose them to our panelists. So thank you again for submitting those questions ahead of time, and I think we'll get started with those. So Joanne, did you want to bring up the questions for us?
Sure, and like Dr. Metcalf just mentioned, we tried to do our best to kind of pick apart the common themes based on all the questions we received, and we did try to do our best to be as comprehensive as possible. So Dr. Bernardini is joining us, so even though he was slated to go first, we're gonna skip his question and go on to the first question for Dr. Eisen. And this is something that came up in our questions that we received. And a few individuals had asked about whether annual screening mammography and MRI at the same time was as effective as having alternating screens. So MRI at a 6-month period and then a mammogram in the next 6 months. So Dr. Eisen, what are your thoughts on this screening regimen?
Thanks very much. Well, in one way, it's a bit difficult to answer because we don't really have a study that compared alternating the scans versus doing them all together. All of the trials really that looked at screening MRI in addition to mammogram used the approach of doing them together. And most of the reason for that is that you generally need additional imaging to investigate MRI abnormalities. So if you did the MRI alone, you'd you would probably need a mammogram or an ultrasound to look at the abnormalities in more depth. And it's in Ontario where we have a high-risk screening program that's a high quality program. You actually have to give the studies as close together as you can. And sites are actually penalized if they spread them out too far. So we don't really have the option of doing every 6 months. I think the concern is people are worried that something will come up in the 6-month interval. And the early analysis from the high-risk screening program doesn't show that to be a huge issue. As you know, many of the participants in the high-risk screening program do end up getting screened or getting additional tests in the 6-month interval to follow up on abnormalities that might have been detected. So the bottom line is we don't really have definite evidence to answer that question. The studies looked at doing them together, and if there's any concern, a 6-month study is usually ordered.
Okay, this next question is for Aletta Pohl, our genetic counselor. And this has come up in, I think, almost every one of our seminar series, and I think it's an important question. And this entails the age at which an individual should seek genetic testing.
So I think that depends a little bit on the situation. I think probably what most people here are concerned about is a parent perhaps who knows they carry a BRCA1 or BRCA2 mutation or another gene mutation, and they're wondering about what age their child should seek genetic testing, their healthy child. So for most of the genes that we're looking at, they're just adult onset conditions. And so we won't test people typically before 18. The only exception is for some genes where it may have implications for the child before that age. But you don't have to rush out typically at 18. For BRCA1 and 2, we typically suggest that people consider getting predictive genetic testing around age 25, because that's usually before the cancer risk is really starting, but when people can be kind of old enough to process this information and it can be useful to move ahead with it. There could be exceptions in the family. If there have been very early onset cases, then sometimes we may suggest that they come in a bit earlier. So like say if someone in the family had breast cancer at 28, then you may want to do it earlier in the early 20s. But generally speaking, that's what we would be thinking for the predictive testing. Now, if you're just talking about people with breast cancer, we're trying to test the usually newly diagnosed people as soon as possible to find out if their breast cancer happens to be as a consequence of a gene mutation that could impact their treatment.
Great, thanks. Dr. Bernardini, do we have you back?
Yeah, I think so. Can you hear me better now?
Yes.
I like, by the way, at the bottom it said I'm Dr. Brady, so I like that. I'm going to try to channel Tom Brady's excellence.
There you go.
Okay, sorry about all the technical difficulties. Hopefully we're better now. So this is obviously a question that's been asked for many, many, many years. And I would say billions of dollars have been spent around the world trying to sort of get to this. And I think as we start to understand ovarian cancer, and there's a lot of people are starting to use type 1 and type 2 definitions of ovarian cancer, and hereditary breast and ovarian cancer syndrome tends to follow the type 2 ovarian cancers. And these are the ones that we think originate from the fallopian tube, not from the ovary itself. Whereas with our type 1 ovarian cancers, which tend to be some other subtypes, endometrioid or clear cell, those are ones that tend to be as a single mass. So when we're talking about really, again, hereditary breast and ovarian cancer syndrome, we're really talking about cancers that are originating from the fallopian tube. They happen to be the most common type of ovarian cancer, obviously, as well. Most studies have not differentiated that, I would say that initially, in their creation, meaning that they haven't isolated and focused just on high-grade serous ovarian cancers. They have focused on all ovarian cancers. There are really two big studies, I think, that have helped us in this question. The first one was the study that combined colorectal cancer, prostate cancer, ovarian cancer, and lung cancer, and longitudinally followed people with screening strategies. And they did not find it to be effective in changing the survival of women with ovarian cancer. The next study was one called the UK Tox study from, it's about probably 5 years old now, but that again tried to ask the same question. They used an innovative formula of the CA-125 being age dependent with the ultrasound. And then they also used just ultrasound itself, interestingly. They did not show any difference in overall survival in that study. But what is interesting is that there is a bit of a spreading of the curves towards the end. And what it means, and that's why I think what's really important here is the word early on your question. Because when you think of early, we like to think of just on the ovary or just in the fallopian tube, and we can cure just with surgery. That's what we really think of. And unfortunately, the study again confirmed that we just can't do that. And I think when we counsel patients, it makes a lot of sense because the fallopian tubes essentially are a tube that spills into a big cavity, a big open space in the abdomen. And so we know that the spreading of the cancer cells happens very early, in which case, even if you're doing ultrasounds every 6 months or once a year, we're not able to get it just perfectly right because the seeding, if you will, happens probably at the microscopic level. We have some cases where people have CT scans 6 months before they present with stage 3 ovarian cancer, and there's nothing on the scan. So you're really dealing with a very, very short interval of time. Really, this is why we think it's so important for women to do risk-reducing surgery for those who are deemed at risk at age-appropriate times. And that's made a big impact in the number of cancers we're finding.
Thanks,
Thank you.
Dr. Bernard. So really important take-home message there is the importance of this preventive surgery in women with the BRCA 1 or 2 mutation at the appropriate age that we've talked about in some of the previous sessions.
Oh, and actually the next question was up for Dr. Bernardini again, and it's actually a good follow-up question, I think. So what type of screening in that case is recommended for mutation carriers following preventative surgery? And along the same lines is whether women should also be getting a regular pap smear.
So there's 2 questions there. I'll tackle the first one. When we counsel patients who have risk-reducing surgery for ovarian cancer, for the most part, we counsel that their risk has now been reduced to someone in the general population. Interestingly, the risk is not 0. You would think it should be 0, and it's not 0, but we are seeing fewer and fewer cases as, again, we do these procedures at age-appropriate times. When we first started doing these procedures, it was women post-menopause, or let's say close to menopause, and there was no question we were finding some cancers earlier at that point in time, and the numbers of women who had cancer coming back was also much higher than it is today, what we're noticing. Given the fact that someone's risk has been reduced to essentially the same as someone in the general population, we would say that there is no effective screening once they've had their oophorectomy. They should, Salpingo oophorectomy, I should say. They have had their risk reduction. They have done what they need to do, the best that they can do for their health. And now they should really be treated like anyone else in the general population. Of course, it does create some angst for people, but we try to reassure them. In the case where we find precursor lesions, and we're starting to find more and more of these as we look for them, still lesions, stick lesions, we have at this point followed those patients with regular ultrasounds and CA-125, although there's no data to support that either. Regarding the pap smear, so pap smears at this point, although people have tried to explore its use for other purposes, including early detection of ovarian cancer, that has not been successful to date. But what has been very successful for ovarian cancer, for cervical cancer prevention is the pap smear. So the pap smear is done for the cervix, has nothing to do with the ovary, nothing to do with the uterus. And if the cervix is still in place, then absolutely someone needs to continue to do their pap smears in the same way they would have done before their risk reduction surgery.
Okay, great. That's very helpful. Thank you, Dr. Bernardini.
Okay, do we have the next question? Along the vein of screening, now we'll switch to breast screening, Dr. Eisen. So thinking about women who've had a preventive mastectomy, so those women without a previous diagnosis of breast cancer, they've elected to have both breasts removed preventatively. Should those women be having screening after their surgery?
Currently, the recommendation is not to do radiologic screening after bilateral preventive mastectomy, because really almost all of the breast tissue has been removed, and we rely on clinical exams and clinical follow-up. I think where this question might be coming from is in women who have breast reconstruction, either with their own tissue, autologous tissue, or with implants. Sometimes breast imaging is ordered, but that's not screening. That's typically diagnostic tests. If there's a lump or some changes in the reconstructed tissue that are felt, we can do breast imaging to investigate that a little further. There's also the whole issue of women who've had textured breast implants, reconstruction with textured breast implants, which are associated with a low risk of a rare type of lymphoma. And there's a discrepancy between the recommendations in different countries. So in Canada, the current recommendation is not to do routine MRI screening in women with textured implants, only if there are clinical features or clinical indications to do that. So that might be where people are seeing some concern about doing some imaging after mastectomy. But in the general healthy woman who's had bilateral mastectomy, without any reconstruction, there's no role for breast imaging. And with reconstruction, it's only if there's clinical concerns.
Thank you. That's very helpful.
You're welcome.
Dr. Aletta, I think it's your turn. And the next question is for you. So should individuals who were tested several years ago or who received a VUS, so a variant of unknown significance, recontact their genetic counselor and be retested?
So this is a bit of a complicated question, and there's different groups and the answer is different for different people. So if there's a situation where somebody has breast cancer and a strong family history, they did genetic testing and they didn't find anything, and at the time maybe they were only doing BRCA 1 and 2 testing, that person should absolutely have updated testing. There's more genes we're testing for now, there's more information, so those people should be coming forward for updated testing. It is different if someone had testing before and they found a mutation, say a BRCA1 mutation, and all the cancer in the family is explained by that BRCA1 mutation. There is technically a very small chance that maybe in addition to that BRCA1 mutation, there's another gene, but we don't, there's no clear recommendations or guidelines around this. There's no clear necessary need for it. There could be occasional cases where if the BRCA1 mutation is inherited from one side, but there's a bunch of family history on the other side that's unexplained, maybe that person could come in for updated testing. But there's not a clear, yes, you should, no, you shouldn't answer. It's a little bit dependent on your family history and situation. And if you have a question, you could always just check with a counselor to see if it's worth doing updated testing or not. In terms of a variant of uncertain significance, this is a change that was found in a gene where they don't know if it actually causes any cancer risk or not. It could be completely benign, but there's a small chance it does contribute to cancer risk. In theory, you don't need to be retested in that variant is there. And if you test again, it's still going to be there. What can change is our understanding of what that variant means or not. But you often don't need to go for testing to do that. You can just reach out to the genetics clinic where you were seen and ask if there's been any updates in the interpretation of whether that particular variant causes any cancer risk or not, because over time that can change. In terms of if you were tested a long time ago for a variant, you could be tested now and they now realize it's benign. But again, it would be warranted maybe if there wasn't anything found before, then you may want to go to get updated testing for other genes. And in the same time, there may be new interpretations of the variant. So it's not an easy answer, but if you have questions, try reaching out to the counselor, just check in and see maybe what it is for you.
Well,
Yeah.
thank you for a really succinct answer to a complicated question, Aletta. So as Dr. Kelly Metcalf mentioned, we had to kind of last minute change plans with Dr. Narod. So we recorded his session accordingly. So we grouped all his questions together. I'm not sure right now, am I sharing anything? No. So there were quite a few questions. Can you see the questions right now?
Yeah.
Before I share the video. So the risks of other cancers and mutation carriers, what other genes are important for hereditary breast and ovarian cancer. We know that individuals are being diagnosed with mutations in other genes. The impact of hormone replacement therapy on cancer risk, as well as IVF treatment. So hormonal exposures and cancer risk in high-risk women, and the impact of breastfeeding on breast cancer risk. So these are all going to be tackled in the next little video. I will try to share with you in 1 second.
Good afternoon. We have several questions today about different kinds of cancer, different kinds of genes. And certainly we're talking mostly BRCA1 and BRCA2 are our patients, and the main cancers we think about are breast and ovarian cancer. But there are other genes involved and there are other cancers that are involved. So a question whether the risk of other cancers beyond breast, prostate, and ovary for BRCA1 mutations. Well, we've actually been following several thousand women, not men, but thousands of women over the last 20 years. And we actually record all the cancers that these women have gotten. And in the 20 years, certainly the majority of those are breast cancer and ovarian cancer. Hundreds of cases, actually. But there's been a few cases of other cancers, but they're rare. We've had 10 cases of pancreas cancer in the 8,000 women. And we had 10 cases of colon cancer and lung cancer. But I don't think the lung cancer and the colon cancer are more frequent than we would expect in the general population. I think the pancreatic cancer is a little more common in the general population, but the good thing is the risk is really low. It's far less than 1% a year. And so I think at this point, we don't really have any recommendations for screening for that or for prevention, largely because the risk is so low that we don't to screen a lot of people to identify cancer. And also, our means of screening are so effective, and you can find pancreatic cancer early. So I think certainly for women with BRCA1 mutations, you should focus on the breast and the ovarian cancer, both by thinking about screening. For ovarian cancer, we talk about preventing ovarian cancer by preventive surgery, age 35, or BRCA1 carriers, age 45, BRCA2 carriers. In terms of preventing breast cancer, looking to see some early effect of tamoxifen, but largely going to depend either on screening with MRIs every year or preventive surgery. About a third of our patients opt for preventive surgery and 2/3 go for MRI screening. So other genes, there are other genes that are involved. I should say that the majority of the genes we see are BRCA1 and 2. To a large extent, I think the value of genetic testing comes from our ability to do something about it, find the mutation. And so the other genes which we're studying, women's fellows for breast cancer are ATM, LB2, and CHEK2. And we're particularly interested in learning how these risks of breast cancer occur in these women, risk of ovarian cancer is quite low, and whether there's an optimum treatment for these patients. So we're trying to collect lots of patients' information on women who develop breast cancer in the context of one of these three mutations, following to see what the optimum treatment is. One of the questions also we get is, the oophorectomy. That's really one of the key things of hormone replacement therapy. Hormone replacement therapy essentially replacing the hormones with estrogen and progesterone that otherwise would be produced by your ovaries. That's really critical for quality of life. And we find that, there are three kinds of scenarios: those women with breast cancer, no breast cancer, as well as those women who are premenopausal and postmenopausal. Postmenopausal hormone replacement is quite common in the general public when the woman goes into natural menopause. You have estrogen or estrogen, progesterone combination. There are some risks of that, but there's some benefits as well. Here for the BRCA1 and BRCA2 care, we're more concerned with offering hormone replacement therapy. Women who are given a surgical menopause. Remember, I said that for BRCA1 carriers, we either remove their ovaries at age 45, and for BRCA2 carriers, for BRCA1 at age 35, and for BRCA2 at age 45.
Okay, we're finding the quality not so great for some reason when we share the video. So I think we're going to stop at that last question on HRT and give time to our live audience and our live members that are here today. So I'm going to go back to the PowerPoint slides. Honestly, 3 years of Zooming and I still can't do the screen. I'm worse than my kids. Okay. Dr. Bernardini, another question for you. And this is a very, very important question that I'm not sure we have the answer to. Should I be removing my uterus at the time of preventive oophorectomy?
Yeah, so I think it's a challenging question to answer. A lot of people ask it. And like many challenging questions, it's very multifaceted. So what are the things to consider? So anytime you are removing any organ in the body, there is risk associated with that. There are some potential consequences related to the surgery and even in some way afterwards. Although for certain things, it ranges from minimal to some are a bit more. And I think what we need to do when we are in the concept of preventative medicine and removal of organs to do so, we need to be very judicious and not simply say, yeah, just, let's just take things out. The reasons to do a hysterectomy at the same time as a salpingo-oophorectomy would be either because we don't think we have removed enough of the fallopian tube with the salpingectomy alone, or the salpingo-oophorectomy, and that has been answered numerous times now, that the risk reduction from an ovarian cancer perspective does not change with the removal of the uterus. So that then leaves uterine factors that would potentially put us at risk. So we just heard Dr. Narod, and the questions are with BRCA1, BRCA2, or other types of mutations. Are women at risk for uterine cancer? And the literature to date has been a little bit mixed. There were a couple of studies that showed a very, very small increase risk with serous ovarian uterine cancers. But there has been some other studies that have also said that is not the case. One thing that is important is that it really takes the operation from a 1 to a 5, let's say. So the removal of someone's ovaries and the fallopian tubes is a very straightforward operation that takes between 20 and 30 minutes. The addition of the uterus adds, at some level, another hour or so, and a degree of complexity. Now, it's a very safe operation that's done quite regularly. But again, for the purpose of why we're doing it, that's what we have to be asking. Now, one of the questions around hormone replacement therapy that's been asked, things certainly are easier for women if the uterus is removed because they don't need to take the progestin. And some studies in the past have shown the combination of progestin and estrogen can increase some risks. With regards to breast cancer, one of the questions I have for Dr. Eisen, and I noticed she has her hand up, so I guess she has a question for me, but a lot of the studies that we have in terms of breast cancer risk and hormone replacement therapy was pre the era of double mastectomy. And I just wonder how the double mastectomy may change that in the future, especially in triple negative breast cancer. So that's a question just for you to think about there, Dr. Eisen. But ultimately, our recommendation is, unless there are certain circumstances, meaning they have a mutation, let's say in one of the Lynch family genes, which definitely puts them at risk for uterine cancer, or if they have some pathology of the uterus, some fibroids, bleeding, that we don't currently recommend it as part of the risk reducing strategy for ovarian cancer.
Dr. Eisen, I see you have your hand up.
I do. I wanted to add a comment too. I'm not sure I want to address that HRT question right now, but it's a really good point. If you've had your ovaries removed, you've never had cancer, you're on HRT, and you've had your breasts removed, do you really need to stop the HRT, at age 50? Like, we've been kind of dogmatic about that. And in my own practice, I don't, if someone's really having trouble coming off of it. But the other issue I wanted to raise about the uterus is just, it comes up a lot for women who take tamoxifen. And they ask because there's a very low risk of uterine cancer on tamoxifen, should they have their uterus removed? And my own belief is that should not change the standard recommendation, that the risk of tamoxifen related endometrial cancer or uterine cancer is extremely low, about 1 to 2 in 1,000 per year. And there's thousands of women on tamoxifen with an intact uterus. And so I don't think just for that reason you need to have the uterus removed.
And I may just add to that, we know that bleeding, for example, whether it's postmenopausal, abnormal uterine bleeding, is a very early sign in endometrial cancer. So for women who are on tamoxifen, they are counseled to look out for abnormal bleeding. And that's why there's really been no survival advantage to the hysterectomy, even in women who are on tamoxifen. But you're right, Dr. Eisen, that's a question that's been asked for a long time. I guess the other question, because you address those who have never had breast cancer and the age of 50, whether they stop it or not. But I guess I'm interested in the 35-year-old that had a very small breast cancer that was removed and then had a double mastectomy and a triple negative breast cancer. And we struggle with these individuals. And in fact, probably have been recommending salpingectomy alone to buy them a bit more time of hormonal maintenance before recommending take the ovaries out. But I guess that's another important question that is probably difficult to answer.
I agree with you. Those are the hardest cases because those are the most symptomatic women, and we're pretty dogmatic as oncologists that even if it's triple negative, there was a British study quite a long time ago, but that showed that even with estrogen receptor negative breast cancer, there was a trend towards increased recurrences of women who took HRT. So it's probably not just as simple as the ER status of the tumor. And those are the one group where I think more information about salpingectomy could be very helpful.
And just to add to that, and again, this is going to get complicated, Dr. Metcalf and Dr. Narod have shown that oophorectomy is very important for the treatment of BRCA breast cancer. So again, further complicating the surgery and the chemo and the HRT idea. Mm-hmm. So, and again,
sessions, I think, highlight how far we've come in the last 25 years in our understanding of how to manage women who present with some of these mutations, but there's still more that we need to learn in order to ensure that we're maximizing the best outcomes for all women who have to make these difficult decisions about prevention. So that's why we are continuing to collect all of this data to try and inform some of these questions. So I think we'll move on to the next question. And I guess we've sort of been talking about this, Dr. Eisen, with the mention of tamoxifen. And I know that this is probably, again, not a straightforward question, and maybe not a question that we have data to answer, but could you comment on drugs that could potentially prevent breast cancer in women who are at high risk? And that might be women with BRCA 1 or 2 or other genes. Do we know anything about those other genes that women are being tested for as well?
Okay, thanks. And this is a good example of an area where we've come so far, but it's still muddy, really, because we have good data. So I'm going to wear my regular oncologist hat. I'm going to talk about tamoxifen. There are other drugs that people have investigated and are proposing to investigate to look at prevention. Right now, I'm going to mostly talk about endocrine therapy like tamoxifen or aromatase inhibitors. And just to switch to the breast cancer treatment paradigm for a minute, tamoxifen, it's arguably one of the drugs that's saved more lives from breast cancer treatment than any other drug. It's been around for a long time. It has some side effects that have given it bad press, but in general, it's a pretty safe and well-tolerated drug. And initially it was used in women who had very advanced breast cancer. And because it was so effective, we moved it up to women who were just diagnosed with breast cancer to prevent recurrence. And in those women, it was observed that their risk of getting a new cancer at the other breast was much reduced on tamoxifen. So that led to a bunch of, 3 or 4 big studies about 30 years ago now, or more, that they were started, that looked at tamoxifen in healthy women who'd never had cancer to prevent the disease. And they chose high-risk women in most of the studies, not based on genetic status, because this is actually predated widespread genetic testing, but based on essentially family history and maybe some other endocrine risk factors. And those studies showed that in high-risk women, taking tamoxifen reduced the risk of getting breast cancer by 40 to 50%. But when they went back and tried to see, were there any BRCA carriers in this group, there were very few. In the largest study, there was, I think, 30 carriers. So it was hard to make definitive conclusions. So then others, including Dr. Metcalf, who's an international expert in this, and second breast cancers, have looked at, okay, if you look at BRCA carriers who took tamoxifen as treatment for their first breast cancer, do they also have a reduced risk of a second cancer in the opposite breast? And even that's a little bit mixed. Some studies, and studies where you pool groups of studies together because it's hard to get thousands and thousands of BRCA carriers, have suggested that yes, it does reduce the risk, even if you're BRCA1, where most cancers that develop are triple negative. But maybe when you take account or adjust for other factors like oophorectomy and other treatments and age, it may not have that strong an effect in all BRCA carriers. In a way, that is less important a decision, because if it's being recommended to you for your treatment of your first breast cancer, that's because it's been shown to improve survival and prevent the cancer from spreading elsewhere in the body. Whether it reduces the risk of a second cancer is a nice side effect, if you will, and that is in many women addressed by having definitive breast surgery. So the answer is there's some evidence that suggests that it might be helpful. We don't have direct evidence that it is helpful in BRCA1 and BRCA2 carriers. I think many of us tend to discuss it more with BRCA2 carriers because they mostly get estrogen receptor positive disease. But for a number of reasons, the uptake of tamoxifen is extremely low. Even in women who don't have mutations, who are potentially eligible for it, there's a number of studies that show that less than 5% of women who are offered tamoxifen actually decide to take it.
Thank you. That was a very succinct answer to a very difficult question. So I think if people are interested in exploring this option, you should talk either to your high-risk physician if you're seeing a high-risk physician, or your medical oncologist about the possibility of tamoxifen and whether or not it would be good for you personally. Okay, so Aletta, we're going to go back to genetics 101 and talk about how these mutations, so if someone is identified with a mutation either in BRCA1 or BRCA2 or any of the other genes that we're testing for, how are those mutations passed on to future generations? Can you just give us a recap of that?
So in most cases, what we're talking about is what's called autosomal dominant inheritance. And what we mean by that is, for the most part, you have 2 copies of almost all your genes, because you get a whole set from your mother, a duplicate set from your dad. So for each gene, you have 2 copies. So you have 2 copies of BRCA1. If you're a BRCA1 mutation carrier, what that means is one of those copies doesn't work properly that you got from one of your parents, but the other copy works perfectly fine. When a person who carries a BRCA1 mutation or a lot of these other genes, when they go to have children, when they're making either egg or sperm, they can only put in one of the 2. So it's a 50-50 chance whether you put in the good one or the bad one. And it doesn't matter if they're boys or girls, or if the child looks like the parent or not, it's just 50-50. And they can definitely be inherited from either side of the family. So if a woman was found to have a BRCA1 mutation or a CHEK2 or a POLB2 mutation, they could have been inherited that from dad just as likely as inheriting it from mom. So when we're assessing these families, we always look at both sides of the family, because either could contribute. And when you carry that, it's 50-50 for the next generation. And again, boys and girls, it doesn't matter, it's equally.
So Aletta, we often get a question about, can it skip a generation? So can you just address that as well? So if you haven't passed it down to your child, can your child's child inherit that mutation?
No. So genetically, it can't skip a generation. So if your child did not inherit that mutation, it's not in their genetic makeup. They can't pass it on. It's just not possible because they don't have it to pass on. Now, sometimes it can look like something skips a generation, and that's because someone who carries a mutation doesn't get cancer. So what can happen is, say, a grandparent can pass a mutation on to, say, their son, and their son doesn't get cancer because the main cancer risks were breast and ovaries. Doesn't have ovaries, doesn't have a lot of breast tissue. But even though that person doesn't get cancer, if they're born with that mutation, there's still a 50-50 chance for the next generation. And it can happen with women too, that they're just lucky. And even though they had the mutation, they didn't get cancer. So it can sometimes appear that way. But genetically, it can't skip a generation. It's either there or it isn't. And testing will let you know whether it is or not. And testing is really useful because then we can, if we know someone's at high risk, we can look after them and try to keep them well. And if they don't inherit it, that's fabulous. And then they don't have to worry about it, nor do their children. And this is all assuming that you're not having, your parents weren't closely related to each other. Because that's the only thing, is sometimes they could inherit something from the other side of the family.
Okay, thank you.
Thank you, Aletta. Okay, next, Dr. Bernardini. So what are the possible health concerns of being in surgical menopause at a young age, and what is the best way for this to be managed? And this is probably a very complicated question to answer in the next few minutes, but maybe just the importance of follow-up care and that the fact that options do exist.
Yeah, so I think you're right. It is a complicated question. I think one of the advantages of the familial ovarian program at Women's College Hospital is that we have Michelle Jacobson, who is our aftercare specialist. That means every person that goes through a risk reduction surgery has the opportunity of having their aftercare managed by an expert. And so she is someone who's done extra training when it comes to menopausal health and management, and I think is an incredible resource. I think the question is, again, multi-layered. One of the things we know is that estrogen plays a very important role. It so happens in the world of BRCA syndromes, it can sometimes be seen as the enemy because it can potentially be involved in certain risks, if you will. But we know it carries very important roles in terms of a person's health. A lot of early studies showed that it was important with vascular, meaning that the blood vessels in the body, obviously critically important for bone health and resorption of bone, very important. And then, of course, there are side effects, things like hot flushes, which may or may not be the sole reason to explain sleep disturbances, things like vaginal dryness with intercourse. Of course, these are all important roles that estrogen plays. And I think it's very challenging when we counsel young women who essentially they're completely normal. They don't have any issues, and we are potentially promoting something that's going to affect their quality of life. That's a very important decision. When we look at hormonal management. One big study, it's quite old now, but still seen as a landmark study at hormone replacement after menopause. These are not BRCA1 or BRCA2 carriers. It turned out that prolonged use of hormones had a detrimental effect in terms of heart disease and strokes and blood clots. And that was a real surprise on that study, and has eliminated essentially for many, many people, hormone replacement therapy after menopause. But of course, we're talking about a very different patient population that we don't have really, really good data on. So someone who's 35, 38, 40, 42 to not have any estrogen replacement if the ovaries are removed will certainly have some consequences. Now, these can be managed. Things like local symptoms in terms of the vagina can be managed with either some local estrogen or things like lubrication. Hot flushes are hard ones, but they tend to be transient during the period. Bone health is critical, and very similar to people who are on letrozole, for example, that really have to stay on top of their bone health. That's a very important thing. So anybody obviously that has premature menopause or who is on letrozole really needs to follow that very, very closely. And so one of the things I think that we have done is, again, try to piece all the puzzle pieces together, because if we can still have a very high rate of risk reduction with the fallopian tubes alone, and again, get somebody a little bit closer to a natural age of menopause, then that may be something to be considered. Of course, like Joanne mentioned, Dr. Kotsopoulos mentioned, we have situations where the overall risk reduction of death related to ovarian and breast cancer is reduced with the removal of the ovaries and fallopian tubes. And so, again, this is where I think it has to be very individualized, person to person. And that's certainly what we try to do in our clinic.
And our clinic is phenomenal, and it plays a very important role in the post-surgical care because it's not a one-time visit. I think it's an ongoing relationship with your gynecologist or gynecologic oncologist or whoever is helping manage your symptoms. So thank you. And we also have a seminar series from last year, and the video is posted, where Dr. Michelle Jacobson gave a great longer overview of potential ways to manage your symptoms. Dr. Eisen, do you have a question, or is your hand up?
No, I just wanted to make a comment that I think one thing I observe in patients that I've been following is that the bone health is often something that tends to get forgotten in women who have young oophorectomy. So if that's something, if you think you're in that category, I would check in with your primary care doctor, because we typically don't think about having to check bone density in women who are, 40. So it's something to pay attention to. I don't know if that's your experience too, Marcus.
Yes, absolutely. I think and again, that's why as a team, we certainly try to do that. I mean, I think it's a bit the transition of who is responsible for what. And I think sometimes some primary care practitioners just make the assumption that the person who's done the procedure may be following, especially if they were a gynecologist. And then sometimes that person feels that the primary care doctor should be following. But I think, as Joanne said, it's really a longitudinal follow-up. This isn't just a one-time thing. You need to do this. It needs to be checked on a regular basis.
Okay. So we're going to shift gears a little bit. And I know, Dr. Eisen, you've talked a little bit about this in a previous presentation. So again, people who are interested in PARP inhibitors can go back and have a look at that recorded video from last year. But there have been changes, maybe, I can't remember when you did that, but in terms of some of the evidence in the effectiveness of PARP inhibitors in patients with a BRCA1 or BRCA2 mutation. So can you tell us now what the current evidence is and who is eligible to receive a PARP inhibitor for the treatment of a cancer?
Yeah, I can. I mean, I think there's an important distinction between who is eligible and who can get it right now in Ontario. And I want to highlight that because right now, the only indication for which PARP, or the only setting for which PARP inhibitors are routinely available and funded in our healthcare system are in the treatment of BRCA-related ovarian cancer, where there's ample evidence of how effective they are and how they're changing the history of the disease in these patients. There's evidence from large studies, and I've been involved in one in early stage breast cancer called the Olympia trial, which showed that women who have a BRCA 1 or 2 mutation, who have either triple negative disease or very high risk estrogen receptor positive disease, after they finished all their initial treatment, so surgery, chemotherapy, or chemotherapy first, then surgery and radiation, they were randomly assigned to get either a PARP inhibitor called olaparib or Lynparza, or a placebo. And we now have survival follow-up from that study that shows that the women who took the olaparib lived longer at 4 years, about a 3% difference, which may not seem like a lot, but in breast cancer studies, that's actually a very large difference. Overall, both groups did quite well, but there was an improvement with the olaparib, and that was both in the triple negative and the estrogen receptor positive. So now we're in the point where we have the evidence, but the drug is not available yet. It's going in the United States. It's available through, it's been approved by the FDA. It's going for approval in Canada through Health Canada right now. And then there will be the process of reviewing it to see whether our healthcare system should pay for it, because these drugs are quite expensive, about $6,000 to $7,000 per month, and patients took it for a year. There's also evidence in prostate cancer, advanced prostate cancer, and in pancreatic cancer. So there's a role for the drugs, but in those settings, in breast cancer and in prostate and pancreas cancer, it's still not funded. If people have private healthcare plans, they may cover it at this point, but in terms of equitable access for everybody, we're still not quite there.
And this really highlights the importance for many patients with these types of cancers of having genetic testing, so that they know whether or not they could take a drug like this to improve their outcomes. Dr. Bernardini, I see your hand up. Did you have something to add? Yeah,
I just wanted to follow up that, olaparib in women with BRCA mutated ovarian cancers, it has probably been the most incredible success story in the management of ovarian cancer patients in the last 20 years. We essentially have seen differences in outcome, which are recurrence, and now we have follow-up data in terms of overall survival, which are quite astronomical, to the point where I'm scheduled to speak at an upcoming seminar series, and the topic of the seminar is that in some women with ovarian cancer, can we talk about cure? And that I would say, yourself and Dr. Kotsopoulos, who have been involved in very important research of ovarian cancer for many, many years, would have found that hard to maybe believe, certainly 10 years ago, that could be something to be considered. And so very important.
And very encouraging that these discoveries are being made. So I think we'll move on to one last question for Aletta.
Oh, Aletta, I'm sure you've had this come up in all your sessions, in your genetic counseling sessions, and whether an insurance company in Canada can request genetic test results or discriminate if they see a copy of genetic test results or other records.
So this has really changed over time. And this used to be a very significant concern for people who were considering genetic testing. But in 2017 in Canada, they put through what's called the Genetic Non-Discrimination Act, which means you can't be discriminated against based on genetic test results in your employment or in insurance. So this is a very big change, and it's very helpful and very reassuring to people to know about this. Now, insurance companies can still ask about family history. So that's not going away. And if you have a cancer diagnosis, all that still has to be disclosed, but at least the genetic testing part isn't so much of an issue now.
Great, thank you.
Oops,
So we're getting to the end of time, and I know that there was a question in the Q&A about breastfeeding and cancer risk, and Dr. Narod was going to cover that, but unfortunately that video wasn't good quality. So Dr. Kotsopoulos, that's research that you've done in the past. So could you comment on that quickly in the last couple of minutes that we have?
Yes, and I know we're out of time, but the short answer is yes. Breastfeeding is a significant protective factor for both breast and ovarian cancer. Based on the longitudinal data that we've collected from the study that many of you likely have been participants of, we have shown a significant reduction in the risk of both cancers with breastfeeding. That being said, it would definitely not be a replacement of preventative surgery or intensive screening if you were for someone that did breastfeed, but it is conferring protection against both diseases. So that's basically the answer in a nutshell. And so I think that takes us to the end of our session. We thank the speakers. We know you're all very busy and very important clinicians and do a lot of work to help manage the care of our patients. And we truly appreciate our ongoing collaborative relationships that we have. So thank you for taking the time. This session is recorded, so you can rewatch it or have someone or pass it along. And Dr. Bernardini, you have a question?
Yeah, just because I don't think we got to all of the questions that were in the chat. So is that something that you can follow up with those individuals?
We tried to do our best.
Yeah. And there are a lot of these questions that were asked that are embedded within many of the sessions that we've done in the past. So what I would encourage anybody who didn't have their question answered to go to the Women's College website, to the specific cancer genetics program website, and all of the previous sessions have been recorded, and please watch them at any time. But if you still have questions, I would really encourage you to reach out to your genetic counselor, and if he or she can't answer those questions, they can refer you to the appropriate specialist. So that's important. We want to ensure that you have your questions answered, and that's really why we've been doing these sessions. Things like we've really highlighted today, the change. So for some of you who may have been seen 10 or 15 years ago by the genetic counselor, things have changed a lot since then. And so we're trying to get you the latest evidence to help you in terms of the management of both you and your family. So Dr. Bernardini, if there's anybody that has questions, they could email Joanne and I if they can't find the answers to those questions, and we could get some responses from either you or Dr. Eisen or Aletta.
And no problem. I'd be glad to.
Yeah. Okay.
I think most of the comments were about the poor quality of the video from Dr. Narod. So we apologize about that. I don't know why it looked fine initially, but.
Okay.
So thank you, everybody. We're wishing you a wonderful weekend. We're taking a break from our seminar series for July and August, but we'll be back in September. And I just noticed that I'll be giving the talk, Considerations Facing Young Women with a Mutation. And I think we'll probably be talking a lot about what Dr. Bernardini talked about today. But continue to send your comments to us, continue to send suggestions for seminar series you'd like to see in the future, because we'd like this to be an ongoing seminar series in many years to come. Thank you, everybody.
Thank you.
Have a
Bye-bye.
great weekend, and thank you.